Our next session is on ICU management of severe myocarditis. Our moderator for this session is Dr. Dinesh Chilla. Sir is there with Rainbow Children's Hospital, and he's the chairperson IP Pediatric Intensive Care Chapter 2023. Please, I would request sir to take the chair. And our chairperson for this session is Dr. Rita Chatterjee. Madam, please welcome on the stage. She's Rita ma'am. She's the former professor of pediatrics and dean, Dr. B.C. Roy Hospital. No, I would like to request our panelists here on stage, Dr. Minhaj Sheikh, Dr. Kumar Divakar, Dr. Muhammad Ali, and Dr. Devdatta Mukhopadhyay. Dr. Minhaj Sheikh is a lead consultant pediatric intensive care from Lilavati Hospital, Mumbai. Dr. Kumar Divakar, pediatric intensivist from Tata Hospital, Jamshedpur. Dr. Muhammad Ali, pediatric cardiac intensivist from Durgapur Mission Hospital. And Dr. Devdatta Mukhopadhyay, pediatric cardiologist from B.C. Roy Hospital.
Good morning. All the faculties and delegates present in this critical care hall, I welcome you all for this session. Now the topic is panel discussion on ICU management of severe myocarditis. And I would like to give thanks to the organizer for considering me as the chairperson of this session. And thing is that severe myocarditis is very common but very serious illness which may be masked by its varied presentation unless the medical professionals who are taking care of the children or the persons, because they usually go to the general practitioners, pediatricians or physicians initially. So it is the task of them to find out these cases and so that they can be referred to intensive care cases in good hands and good settings. Now I would request our learned moderator, Dr. Dinesh Chilla, to start the session along with all the panelists. Thank you all.
As an intensivist, we do come across cases of myocarditis, and especially I think post-COVID, a lot of us had seen children who came with features of unexplained tachycardias and coming in failures, coming with some high inflammatory markers, cardiac symptoms. And I was just talking to my panelist about the challenges of pediatric intensivists in managing patients with myocarditis. So, sorry for this glitch, and I hope this is now, yeah, let's quickly, I think my panelists have been introduced. So, myocarditis is something which all of us know is inflammation of the myocardium with many different etiologies, but the commonest mode of presentation is cardiogenic shock or arrhythmia and sudden death. And you have number of viruses which are there, but the commonest one, recently even adenovirus, post-adenovirus, you started seeing them. COVID virus, again, you had MIC, and you can have post-bacterial also, and you will have a lot of autoimmune conditions which can present. And if you look at the different etiology right from 1950 to 2020, you will have different types of viruses which have predisposed to. But there are three different type of places where you can have one is immediate viral illness, where you have a replication. Then you have an autoimmune injury, which is when a virus induces an autoimmune phenomena, where you have a TNF, interleukin markers, which will indirectly affect the heart and create an immunological injury. And if it persists, then it causes dilated cardiomyopathy. And typically, if you see the children, you will have two different types. One is during the incidences during the infancy period, and then later you will find in the adolescent time, which is what we found. To start the discussion, Dr. Minhaj, what is the commonest presentation of viral myocarditis?
Well, good morning all. See, as rightly sir has said in the beginning, we have two ages when we get the myocarditis, or one is early infancy and second is adolescent age. And most of them in early infancy will be something like prodrome of viral illness, followed by unexplained tachycardia and heart failure. So that will be the commonest presentation in the early age. In the adolescent, again, we have some prodrome, followed by congestive heart failure. There we have a congestive heart failure and prodrome. So these are the two common ages and two common phases of presentation, the common that we see in PICUs.
Yeah. Thanks, Dr. Meena. So there is no specific way, like you would say, ki this is the definitive symptoms. So unexplained tachycardia, for the child might have. Definitely some of them may have fever, as you said. None of them are going to close to 70% if you look at them. 50 to 60%, so definitely. But many of them might have fever, tachycardia, some signs of failure is what you see. So let's take a case scenario. A 12-year-old boy, a resident of Hyderabad, came with fever, respiratory distress, abdominal pain. There was no contact with COVID. On examination, had tachycardia, tachypnea, SATs were 88% in 5 liters of oxygen. The blood pressure was sitting in 85 and 50, 12-year-old boy. JPP was elevated, weight was 35 kg, GCS was normal, had distress. Crepitation were present, there was a gallop, and then liver was enlarged. Dr. Minas, how do you proceed from here?
Well, the classical teaching has been to look after the physiological status. In this particular case, if you see, the child is in nutshell, the hypotensive shock with respiratory failure. And this is probably because of, in view of gallop, rhythm and all, is cardiogenic shock. So we have to take care in terms of cardiogenic shock. And the classical ways, again, A, B, C, D. The first thing is oxygen delivery. So have specifically not low flow, high flow oxygen. Start from higher, better modality of oxygen delivery. Second is, again, take care of like oxygen consumption by agitation, fever, all those things have to be taken care of. The next will be to give small boluses. When we have a cardiogenic shock, the boluses have to be careful. What I always say to my units, what is gone inside will not come out. But you can give gradual and see the response. In the subsequent slide, we'll talk about what is fluid responsiveness. However, here, a careful, titrated fluid can be given and see the response to begin with. So oxygen, airway, vascular access, and small bolus will be initial management.
So the message is here, as you say, you found this child was hypotensive, was working very hard. So oxygenate the child well, ensure that the airway is fine, breathing is controlled. And when you're giving fluid, it is very important to recognize how to give the fluid. And here is when, I would like my question for Dr. Mohammed. See, a lot of time, when a child comes with hypotension, we tend to give fluid boluses, isn't it? So what is fluid responsiveness? Why is it important to assess that?
Yes, sir. So most important things when we are resuscitating a child with shock is the first step is to optimize the preload. Otherwise, you can't improve the cardiac output. So for optimization of the preload, we have to assess first the fluid responsiveness. Because if you give a fluid, if the patient is responsive, then you will have positive result. But if the patient is not responsive or otherwise you will cause lot of harms, like in terms of many things. So if I give a fluid to the child, it may be real fluid or it may be the virtual fluid, so that we can manipulate the preload and see the response of the cardiac output. So if the cardiac output measures by various methods, it may be like with the bedside echocardiography to the aortic valve velocity time integrals and the stroke volume assessment. If the response is more than 10% with a given fluid, then we call the patient as fluid responsive. And that patient, if required, if the patient is hemodynamically compromised, then only we give some fluid.
Yeah. So the important message what to give is common thing for us is child with septic shock, give a lot of fluid bolus, give 10 ml per kg, 20 ml per kg. Sometimes you come across pulse teaching and other things. Especially recognize if the child is into a cardiogenic shock. Yes, little extra fluid. Why do you give fluid? You're trying to increase the preload, isn't it? So that, your stroke volume increases indirectly. But this excessive fluid, is it going to cause further increase in the cardiac the heart is already over distended. So there are different measures for us to know how the heart is, whether the heart is already filled or it needs more of these things. So how do you know whether the child is unresponsive, Dr. Divakar?
Yeah, So before giving fluid boluses, we should have the baseline heart rate. So you have the respiratory rate, you have the respiratory distress, assessment of respiratory distress. Then you should put a stethoscope and see if there is basal clips or not. And then you have the level measurement. Once you have given the fluid bolus, especially in a small aliquot, then you again go and look at the heart rate. Is it increasing or decreasing? So if it's going up, probably it's not responsive. Respiratory distress is worsening, then probably it's not, fluid is not helping in anything. Then you look at the crepes might have gone up, increased, or liver size has gone down. So these are the clinical features which indicates that fluid is not helping our kid here.
Yeah. So the message for the residents who are there, don't give fluid order on the phone. Don't say to the nurse to give a fluid bolus of 5 ml per kg or 10 ml per kg. Be on the bedside and give the fluid and look at the heart rate and the blood pressure when you're giving the fluid. If you find child is suddenly coughing, child's heart rate is in fact going up rather than coming down, you know that this fluid is not helping the child. Is there any other way, before giving fluid bolus, you already know the heart's liver size, but sometimes you know the child might not have been fed for nearly 12 hours. Child might still be having fluid depleted. Some other bedside maneuvers or something, Dr. Devdutt, which might help you to analyze, can I give a fluid bolus?
In our unit, before giving fluid bolus, it would always be helpful to do a functional echo and see the IVC and the IVC collapsibility. And like we discussed yesterday in the POCUS workshop group. So I think that would be, for us, that would be the best way to decide on the fluid responsiveness. But of course, bedside leg rising test would also help. That passive leg rising test, if we elevate the leg end, then there will be changes in the stroke volume, and we can calculate the stroke volume index as well as check the CVP going up or not. Yeah. So
I think this has become now, at earlier days, I think, we all have grown up in the days where we didn't have bedside echo to now having echo by the bedside. So we used to sort of look at leg raising and see what happens. But I think with the availability of, if you have an echo by the bedside, that's probably the best side. Look at your IVC and see what's happening. And to see if, suppose, you have already dilated IVC, and there's not much of variation happening, you know that that's not going to help you much. Now, Dr. Minas, see, how does inotropes makes your heart more responsive, even to the boluses and other things? How is it making it?
Yeah, this slide is very important and very lovely slide to understand, this is basic Frank-Starling curve. And we need to understand at what point of time where our patient is there. Our patient is variable. At 10 a.m. is different, 12 noon is different, at 3 p.m. is different. So you have to see where my patient is lying, number one. So careful fluid titration and see the fluid response where my patient is there, number one. Number two, once the tank is full and if you have signs of fluid overload, it's better to go early inotropes. So this is exactly what has been there. The failing myocardium has a limitation with regard to fluid responsiveness. The same myocardium, once introduced the inotropes, will have the better stroke volume. So early careful institution of inotropes after adequate fluid resuscitation. Adequate means not too much, not too less. Appropriate fluid resuscitation will help in optimal management.
So you saw the Frank-Starling, like the UMO of fluid was, in fact, it started coming down.
Yeah.
But once you put the inotropy on board, you will find that this is already covered. It starts sort of, improving. Now, Dr. Divakar, so we all know that we need to start inotropes on this child. This child was hypotensive, you give small fluid bolus, you can't give more than that. So the next things comes up is, okay, what do I do? Which inotropes? He's got LV dysfunction, which one I have to use? If he's got a hypotension and with dysfunction, which one to use? Or if he's got a RV dysfunction, which one to use? So how do you choose the inotropes or inodilators in children with myocardial dysfunction?
So when cardiac function is compromised, the basic principle of treatment remains the same. You have to reduce the afterload, you have to reduce the preload, and you have to increase the contractility. You do not want your heart to work against increased afterload. So already you have challenged with the fluid is not working, so this is the time you start working on the increasing the contractility. So you have either you can go adenosine group of adrenaline, or you can go the milrinone. The issue with the milrinone that we should have a normal blood pressure before starting the milrinone. Second issue with adrenergic group is they are chronotropic, they are arrhythmogenic. So we should start adrenaline only if you have the hypotension. With the normal blood pressure, we should go for either for the milrinone or the dobutamine, because it will it reduce, not only reduce the afterload, it also increase the contractility. So one drug you get the effect of reduction in afterload as well as increase the contractility. And you have already restricted the fluid, so you are taking care of the preload as well.
Yeah, thanks. So, for very good message, Dr. Divakar, thank you. So, fluid is adequate. So, now you're basically talking about inotropes, trying to just make it very simple. So, if you are hypotensive, the first thing for you is to get the blood pressure up. So, you need to ensure your blood pressure is adequate. So, there is no point in starting milrinone in a child who is already hypotensive. You'll drop your blood pressure further, you'll compromise your coronary perfusion further. So, you increase by giving epinephrine. So you don't worry about afterload at that time. You first have to improve the contact. Then you choose your milrinone or dobutamine. So I think, Dr. Devika, being a cardiologist, I know, see, a lot of time I think intensivists are very scared. Milrinone, dobutamine, they probably go for dobutamine as the easier choice. So how do you say to message to say when to use milrinone, when to use dobutamine, what are the precautions when using milrinone?
As you suggested that we have to take care of the blood pressure foremost before starting milrinone, and because it has got a longer half-life and hence it has got the risk of putting the patient into a hypotensive state again. Usually it is restricted to 48 hours and we cannot give a much extended use for it. And so for us, I think in this situation, a dobutamine would be a more acceptable alternative, but we have to keep in mind the tachycardias also, because dobutamine has a propensity to cause a lot of tachycardia.
Yeah.
So
I think the message is clear. So milrinone acts very nicely, but you be careful about your blood pressure and this. So I think we got the message that you child with cardiogenic shock, you choose your inotropes right, be careful with your fluid. The next question comes is how do I monitor this child, isn't it? So Dr. Minas, so what sort of monitoring would you suggest?
Well, it's very simple. It's a bedside. So we have to be on the bedside of the child, number one. And number two, therapeutic endpoints of shock. It's very clinical, not too much of, so you have to look for the heart rate, you have to look for the blood pressure, look for the cardiac rhythm, because this myocardium is irritable. So look for the cardiac rhythm, and then look for the urine output, end organ perfusion. If you have a good urine output without diuretics, probably your child is doing well. And if you have a luxury of having the gas, look for lactate. A downward trend of lactate in early phases, that means you're on the right track. So, and look for like perfusion. Your extremities, it should be warm, the pulses should be well felt, CRT should be less than 3 seconds. So if these markers, the bedside markers coupled with lactate is there, this is the simplest way of monitoring, but of course on the bedside and round the clock.
Great. Thanks, Dr. So clinical monitoring and your sort of, investigations what you can. So you are having continuous ECG, because I will come to that, how they are predisposed for arrhythmias. And of course, sort of having an invasive blood pressure is very important, because if you just can't rely just on your non-invasive blood pressure measurement, because when they go into hypotension further, because especially if you're inotropes, and I suggested lactate seems to be very good, sort of for you, a downward trend in lactate, a very good sign. So look at this child. This is an X-ray of this child showing some evidence of cardiomegaly, congested lungs. That's an ABG. And so now we get a lot of children, Dr. Mohammed, with cardiogenic shock, and some of them have dilated cardiomyopathy, some of them might have. So when do you actually say, I'm dealing with myocarditis? What makes you think that is this myocarditis?
So like if you have few clinical scenario, then I will suspect that patient might have like myocarditis. So if first scenario is when I am resuscitating a patient with shock, if the heart rate means if there is some kind of disproportionate tachycardia, obviously it is very subjective at that situations. Second, if we have a tachyarrhythmia, in that situation, and if you have a new onset like heart block, these are the three clinical scenario when I will suspect some kind of the patient might have myocarditis. So obviously we have to do some investigations. It is all of clinical. Then we have to confirm with some investigations. So with baseline investigation, some markers of cardiac injury, bedside ECG, 12-lead ECG, and echocardiography. And for confirmations nowadays, the diagnosis of myocarditis is confirmed either by cardiac MRI or by biopsy. But because of the evaluation of the cardiac MRI, biopsy is not now a preferred mode of confirmations.
Okay. So, thanks. So, you have some disproportionate tachycardia. You control the fever, you almost optimize your fluid, your inotropies is fine, but tachycardia seems to be disproportionate. Or you're having arrhythmias. Are you having a cardiogenic shock? Perfusion continues to be poor. You know that something is going down with the heart. And as a recent viral prodrome, which was there a week back, or continuing to have viral sort of recently. These are sort of some of the symptoms which, as told by Dr. Mohammed. And these are some of the investigations which were sent on this child. ESR was slightly raised, and calcium slightly low. Ferritin was high, procalcitonin was high, and interleukin 6 and D-dimer was also elevated. Very quickly, the ECG sort of, in these children does help in sort of diagnosing. They have sort of, Dr. Divakar, before I go to the next, explaining sort of, if you say, how does ECG help? Do you go by the monitor ECG? Do you do a bedside ECG to diagnose sort of myocarditis? How does it help?
Okay, so we just have an ECG session. So it's not very difficult as we have seen in the previous session. You should always go for the 12-lead ECG and you look for the sinus tachycardia. So then you can see the limb leads and low voltage QRS complex. You can also have a long QTC, and atrial enlargement you can see with the YDPR, P waves. Yeah. And in the latter, you can find the left force dominance, and also you can have the ST change with developing ischemia.
So it is not compulsory to have arrhythmia to diagnose myocarditis. It is not compulsory for you to have ST changes or ST depressions to diagnose myocarditis. You might have low voltage sort of QRS complexes. You might have mild changes in your QTC, but just remember that ECG will be helpful for you to diagnose sort of myocarditis. Dr. Deva. Now we had a long, so I didn't want to again go through arrhythmia. You had a very nice sort of a panel on that. But arrhythmia seems to be one big problem, sometimes leading to cardiac arrest, isn't it? So how significant it is in myocarditis, and how do you monitor them? And briefly sort of what should be the intensivist be ready in a child with myocarditis?
Yes, this is a very important aspect because the myocardium is already predisposed to arrhythmogenic potential, that is, the threshold has decreased and we are giving a lot of catecholamines. So naturally, there is every possibility that the child can have various sorts of arrhythmias. The child can break into short runs of VT, can have occasional ventricular ectopies, can have a prolonged PR interval, first degree heart block, and in very severe cases in specific infections can also lead to a complete heart block as well. So we do need to have a look on the ECG every now and then, at least in the, and if we suspect something in the monitor, then we should always take a 12-lead ECG with long lead 2. And also it has got, if it is a very fulminant type of myocarditis, in that case, if we are having arrhythmias, then it has got a prognostic implication, especially related to ECMO and all.
Yeah.
So
I think one thing we always do is we always keep things ready, because the children with prone for arrhythmias could be supraventricular tachycardias, could have ventricular ectopies, and heart blocks. I mean, it can have any of them. So we need to be ready with your antiarrhythmic agents along the bedside for these patients, so that we prolonged arrhythmia can lead to sort of severe cardiac dysfunctions, and these are the children who ultimately may lead to cardiomyopathy, might need sort of ECMO or ventricular assist devices in future. So I think Dr. Minaz, very quickly, because we did touch base on echocardiography.
Yeah,
So how does it help, sort of? Because I think Dr.
From intensivist point of view, couple of things. Number one is IVC. Number two is cardiac functions, ejection fractions and all. Number three, how is the valves are there, and some effusions and all. So if these things, important thing from the prognostic point of view is LV. How are the ventricles? If the initial phase ventricles are not dilated, probably we are going to have a better outcome. If the ventricles are dilated, the outcome may be guarded. So these are and we have to keep on, I mean, not every day, but we have to keep based on the clinical scenario, repeating the echo, but not every day otherwise. Yeah.
So it helps in more in prognosticating and also ongoing management. Suppose if you are having shock, ongoing, not recovering, you could sort of have this. Now, typically coming back to this scenario, what type of respiratory support these children need is what we come to know. So we always have this, whether you should go for non-invasive or invasive ventilation. How does this indication of the respiratory support make a difference to children with cardiogenic shock?
So basically, sir, any kind of positive pressure ventilations will help this child. So it will reduce your overall body oxygen demand, that is the DO2. So you know, normally the respiratory muscles require only 5% of your cardiac output, but in respiratory distress situations, your cardiac output, around 50% of the cardiac output will be shunted to the respiratory muscles. So if you just alleviate the respiratory symptoms, your cardiac output will be distributed to the other organs. Second, by reducing the transpulmonary pressure swing, it will reduce your LV afterload. Third, this child is already congested. So giving positive pressure ventilations, it will reduce the venous return and thereby will improve some kind of pulmonary mechanics. So by all this, the positive pressure ventilation will be beneficial for this child. Now the thing is, this patient is already in shock and requiring inotropic supports, and his condition is probably deteriorating. So in this situation, considering the non-invasive mode of ventilation will be little tricky. So probably we have to go for the invasive mode of ventilation.
So I think rightly said, it reduces the work of breathing, takes off the load on the heart by reducing your afterload. So that way, sort of, it does improve your cardiogenic shock. So definitely, when to go for NIV, when to go for invasive ventilation is always these things. Specifically, if you are in a hypotensive shock or if you are failing on NIV, then you know that you probably have to go for a invasive ventilation. But very important is, when you are intubating, it is very important that many of children, and those who have intubated, they know, these children can certainly arrest on you, especially if they're in shock and they are trying to intubate this child. So it's very important for us to know what drugs we are giving, So don't give the medications which will further drop in the blood pressure. So then if you give some midazolam to them, the blood pressure further drops, they can certainly arrest on you. Give something like ketamine and fentanyl instead of midazolam will probably help you to sort of maintain the coronary perfusion and prevent such type of problems. Now, in a periphery, sometimes you do sort of suspect Dr. Divakar myocarditis. So how because sometimes they may be lightly mild and other things. So how does someone says, I need to keep this child in PICU? What is the message for people?
So mild myocarditis you can manage, but once they develop complication, they are going into hypotension, cardiogenic shock. They must be managed as a tertiary care PICU only. If you don't have it, please refer.
Yeah. So I think most of the mild one goes undiagnosed. So once I think it comes to our notice as the pediatricians, we know that they need to be referred to the PICUs till we are sure that they are not having any sort of evidence of arrhythmias or anything. So let's go back to this case. This child had a pro-BNP of 3,140 and troponin 164, which is 100 times higher. So, Dr. Devdutt, I think this is something which we don't order very frequently. Cardiologists order a lot more. I think MIC during COVID, now even the pediatricians came to sort of doing more. Adults order a lot more. What is the utility of troponin 3 and I in managing myocarditis? And are there any fallacies of those reports in sort of interpreting those reports?
Actually, troponin I and T, it's an established biomarker for myocardial injury, either ischemic or even in the case of myocarditis also. But the thing is that it doesn't always correlate with the radiological finding. Like the echo may show, on the functional echo may show a normal function, but the troponin may be elevated. So there is a child with tachycardia and elevated troponin, but with a normal or near normal function in the echo. So that becomes a diagnostic conundrum for us. Also, it has been shown that in the initial phases, it is because of the ion channels passing through the increased permeability of the cell membrane, which is causing the high levels of troponin. So, in a kind of a negative predictive view, if we can say that if there is not much tachycardia, if there is no increased troponin, then we can be rest assured that it's not myocarditis.
So it's a good negative predictive value. So if you have a normal troponin levels, for someone says it's acute myocarditis, I'm referring to you, and you send a troponin levels comes normal, the heart rate is not too bad, you can probably safely say it probably not. So it's got a good negative predictive value. And we send out the nasopharyngeal swab, and this post-COVID things, we got both adenovirus and COVID-19 also had come positive, but as the microbiome advised to consider adenovirus, because this was all we were doing the epidemic of adenovirus recently. So we took adenovirus as possible etiology for this child. Now, yeah.
When we have an elevated troponin levels in our unit, and we are suspecting myocarditis because of tachycardia, then we don't restrict to functional echo also. We do an extensive function analysis, including strain studies as well.
Sure.
All the detailed studies, RV function studies and LV function studies in details. So that
what about pro-BNP? See, pro-BNP is again goes very exaggerated.
Yeah.
Sometimes it's a marker of inflammation also. And we have seen that, specifically during the COVID time, it became one of the markers as part of your MIC.
Yes. Any cause of dilatation of the ventricles, and even if the fluid overload is causing some dilatation, that can also cause a raised pro-BNP. Yeah. It doesn't always correlate that much, but a high levels definitely should suspect.
Dr. Meena, see, is it virus very important for post-myocarditis, or you can have autoimmune?
The myocarditis is associated with viral illnesses, but the point is that the actual injury to the myocytes has a multifactorial effect. So it is multifactorial, and in fact there is a literature which says, one good editorial, that says that whether it is you really required infection to have a myocyte injury, or whether it is immune mediated. So there are viruses which causes myocarditis, but it may not be always true. It can be without viral infection as well. It can be immune mediated injury. This is what been there.
So it could be viral trigger, or you can have an autoimmune mechanism which might cause the viral injury. So now coming back to this child was on an IV CPAP, dobutamine, Lasix infusion. So somehow this child is not moving forward. So and a lot of us talk about immunomodulation. So Dr. Mohammed, one of the things which talk about is steroids. What's the role of steroids in myocarditis?
Sir, per se, a steroid in pediatric myocarditis, there is no conclusive evidence that shows that it reduces the mortality or other outcomes. But there are few case report or case series that shows that after giving the steroids, the LV ejection fraction improve over the time. So that's not confirmed in most of the RCTs or good quality studies. So now considering this child had two viruses like adenovirus as well as COVID, and there is some kind of inflammatory reaction. So it's a non-specific cytokine release syndrome. So in that situations, based on our recent experience post-COVID, we consider immunosuppressive for this child. So
I think the message is, see, if you go to evidence, you go to Cochrane meta-analysis, they say it's absolutely no evidence, heterogeneity of studies, and really, but if you go, a lot of times, when you're stuck, especially a child is not responding after you give IV immunoglobulin also, especially in COVID-19 phenomenon, after giving steroids, after giving IVIG, children are still not responding, especially in presence of increased inflammatory markers. I think people have used steroids, and they seem to be working in those babies. What about IVIG, Dr. Divakar? What do you, again, myocarditis, and suddenly the nurses start asking, or your registrar start asking, should I give IVIG in these children?
Yeah. So again, if you are strictly looking at the evidence, we do not have enough evidence, enough data to suggest the routine use of IVIG. However, I must accept that is commonly used. There are a specific use, Kawasaki DG, GMC, there is enough and we use it. But routine use, if you strictly go by the evidence, we don't, either from the adult or pediatric study, we don't have enough evidence.
So looking at the evidence, there is no direct evidence supporting both IVIG or steroids. But if you are having a huge high increase in inflammatory markers, there is no evidence of any active infection ruled out, and the child is not improving with your conventional support, that is when they have used IV immunoglobulins, and steroids are the treatment which we have been used. So this child has been on methylprednisolone and IVIG apart from the support with milrinone and Lasix, and so another in the cocktail, when you are pushed to the wall, people talk about, should I use anticoagulant, should I use thiamine, should I use carnitine? Dr. Meena, just sum up, how do you use it, or it's just a cocktail when people think kuch to de do so that something works?
Yeah, I was going about thiamine and L-carnitine in the literature review. I could find one good literature which talks about something called in a chronic deficiency state. That is called as thiamine, nutrition deficiency cardiomyopathy, NDCM. So there are thiamine, carnitine, CoQ, selenium. If there are chronic deficiencies, you can have cardiomyopathy. Not much of literature with regard to myocarditis. And what is the role of all these things in the myocytes is that it helps in the energy production, calcium balance, and some defenses, oxidative defenses. There it is, the role has been there. If you go to the robust literature, not available. However, the literature is silent about use of all these things. In general, we do use, most of us use with regard to thiamine and L-carnitine. This is about this. With regard to anticoagulant, yes. Mild myocarditis, no. If you have a significant LV dysfunction where there is a chances of thromboembolism, we do use. There are two ways of using. With established heart failure and the poor LV functions, and one we can use aspirin and one we can use heparin. So there we use either unfractionated or LMWH. So there is a role of anticoagulant in severe cases, not in the mild cases.
So thanks. So I think when you have poor cardiac function and there is a risk of forming sort of a thrombus or anything sitting either in the heart, in the periphery, that is when you go for the, enoxaparin or any one of the anticoagulants. And they're more of sort of cardiac protective, sort of increase the cardiac function, and people have used this. And I agree with you and try to look at the literature. Not much is available unless you document a deficiency of thiamine, or this people have not sort of shown that it makes a difference. Very quickly, now sometimes you go across two things. We have now more availability of ECMO and ventricular assist devices. Dr. Deb, that what has been your experience of ECMO in children with myocarditis who are bad?
I have very limited experience of ECMO in acute viral myocarditis, to be very honest. But from what I have seen and what I have read in the literature, the recent literature says that early initiation of ECMO is important. That is before the end organ dysfunction issues. Before that ensues, if we use ECMO, it helps. And also, if we have malignant arrhythmias and also a very, very dilated LV, then we can institute ECMO earlier. Sometimes in Western countries, I have seen them doing the atrial septostomy during that ECMO procedure, doing that atrial septostomy to sort of decrease the LA pressures and the LV pressures in a hugely dilated LV. So
I'll quickly sum up. I think we're finishing on time. So I'll say, ECMO, one thing is that if you have a very fulminant myocarditis, you're not winning on the patients. We had a couple of patients. One is when myocarditis is bad arrhythmia, we're just not winning on this patient. We quickly took the child on to VA ECMO, and this child has done very well. There are concerns about, and this was was what they had, out of the 20 patients, they are 85% was the survival. So they do well. They made average on ECMO around 6 days, and they recover. And those who are continue to have poor function, they end up on ventricular assist devices. I'll quickly go through this other thing like stunt thing. But what is role of ventricular assist devices in Dr. Devdutt, and then we'll close it up sort of.
Yes, if there is no recovery of the electrical activity within 48 hours of instituting ECMO, and if there is no satisfactory response to the ECMO after 7 days of constant support, then I think those are the established indications for taking the child to VAD, which will mean that it is a bridge to the transplant.
Yeah. So I think, see, if you have a child with myocarditis, there are sort of, these are the advances in the treatments which are available, and this is what we need to think. So I think we are done with time, that's what Madam is saying. So to close this all, what do you say? Recognizing children with myocarditis is very important, and probably the tachycardia, disproportionate presence of cardiogenic shock, a viral predome will help in. Judiciously using fluids is important, and choosing the right inotropes is important. Choosing appropriate monitoring is very, very useful to sort of prevent sort of any catastrophe. Ensuring immunomodulation is controversial, but many of us use immunomodulation. Being very proactive in monitoring them for arrhythmia is important, and managing them. But some of them have such a poor cardiac function, many of us give up on them. I think with the current advances which we are having, using ECMO or plus or minus ventricular assist devices, if the parents can afford or there is availability of that, is probably what we can look at for future. I thank my esteemed families, Dr. Minhas, Dr. Mohammed, Dr. Devdutt, and Dr. Divakar for their, and thank you, Chairperson. Thank you very much. I think we
Before
thank
we
you
stop the session, I must say a few things. It was a wonderful discussion, really. I loved it so much. It was practical, important aspects were discussed so nicely and vividly at the same time within the limited time. It is really excellent. I must give thanks to all the panelists, Dr. Divakar, Dr. Mukhopadhyay, Dr. Minhas, Dr. Ali, and of course, moderator Dr. Dinesh Chilla. It was nearly, I enjoyed the session.
Thank
we
you.
all loved it. You started from the etiology and you went to ECMO. That is the most important thing, and these are being done, we know. And thanks to all of you. Thanks to the audience also.
Thank you, Chairperson. Thank you so much.
I would request Dr. Shatarupa to felicitate our chairperson, Professor Rita Chatterjee. Our moderator, Dr. Dinesh Chilla.
We want a photo with all of them.
Yeah, sure, sir. Sure, ma'am.
And the panelists, starting with Dr. Devdutt Mukhopadhyay. Dr. Minhas Sheikh. Dr. Kumar Divakar. And Dr. Muhammad Ali. Thank you.
फर्स्ट वाला लगा दो ना, जस्ट पहला वाला लगा दो, प्रेजेंटेशन बैकग्राउंड